So first and foremost, before we get into all the good of why we're here today, I truly want to take a few minutes to introduce to you Alexander Mostovoy and tell you just a little bit about him. So I had to make some notes because otherwise I'll be a bit of a squirrel and go off tangent. I could talk about Alex quite a bit. We all love him and highly respect him. So again, so Alex Mostovoy, he is the president of the Canadian Association of Clinical Thermography, which is hosting these events. He is also a doctor of homeopathic medicine and is a board certified clinical thermologist. Since 2007 until now, he is also the founder and CEO of Thermography Clinic, Inc. He started with one clinic and has grown that single clinic to over 30 clinic locations internationally and has provided thermography to over 40,000 women to date. He's also a clinician, writer, researcher, and public speaker. He is also recognized as a leading authority on breast health and cancer prevention. So after practicing homeopathic medicine for 20 years, he has devoted his full time to medical thermography. He's lectured extensively around the world and has educated and trained physicians in breast cancer prevention and the use of medical thermography. He is also the author of the best-selling book, Breast Cancer is a Preventable Disease. And if you do not have that, it is still available on Amazon because I ordered just a couple more copies the other day. So it's there. In 1999, Alex pioneered the use of breast thermography in his clinic in Toronto, which, as you will learn, is a non-invasive testing method that uses advanced infrared cameras to analyze heat patterns of the human body. So that's just a little insight into Alex, and you'll get to hear from him today. So again, thank you so much, Alex, for joining us today and leading these very insightful monthly meetings. Thank you.
Thank you, Catherine. Let me just share my screen so that we can see the presentation that I have. And just let me know if you can see it. Yeah. Yes? No? Yeah?
Yes.
Okay, great. So I just want to welcome everyone. This series was actually, as I mentioned last month, was the brainchild of Catherine that you just saw a few minutes ago. She came to us, I believe it was last summer, asking if we could do a practitioner series for thermography. So we had an introduction a month ago, 4 weeks ago. I think it was September 20th. Now we're going to be looking at thermography and breast health. And then subsequently, every month, we're going to take a different subject and how thermography kind of positions itself in different places in terms of different illnesses and pathology. And we'll start today, as I mentioned, with thermography and breast health. I have to tell you that I started with thermography specifically for the purpose of screening my own former patients for breast health. And, you know, and that it's coming up to 25 years now. So it's taking off ever since in quite a significant way. It's certainly changed my life. And not to correct Catherine, but she had old information. We have screened over 60,000 women since that, not 40,000. But at this point in time, an extra 20,000 doesn't really matter. So to move along, let me just go to something that I think as people come in, I'll just kind of admit them. So you may hear a different sound, or maybe I'm the only one who hears this. A quick question. If 20 or 12 jumbo jets would crash every single day of the year, would you be willing to continue flying? Now, I know it sounds crazy that every single day of the year, 365 days, we have 12 jumbo jets crashing each and every single day. I know it's almost impossible to think about something like this. Probably very few of you would be very comfortable in terms of using this particular industry because definitely the safety is no longer there. And yet, and by the way, each and every jet contains about 500 people, and that's as many women that are dying from breast cancer each and every day around the world. So there's something that's not computing, at least in my mind, what's going on with this industry. We keep hearing that we are making progress and things are getting better and all this. And I have to tell you that I have to adjust the numbers each and every couple of years. So worldwide, and that's from just 2020 or 2022, 2.3 million women will be diagnosed with breast cancer in that year alone. In the United States and Canada, we're looking at 330,000. We're also looking at 685,000 women annually will die from breast cancer. Many of you know that I published a book years ago called Breast Cancer is a Preventable Disease, and I definitely believe this is the case. But today we are going to be talking about something a little different. I also want to bring up some statistics and some very disturbing numbers. In 1860, so let's say 160 years ago, 1 in 91 women had breast cancer. Today, or just a few years ago, we are down to 1 in 7 women that have breast cancer. In 1920, about 100 years ago, 1 in 8 people had cancer. We're talking about just regular cancer rates, not specifically breast. And again, today, 1 in 3 women will be diagnosed with cancer in their lifetime, as well as 1 in 2 men, which is about 40%. Sorry, just went the wrong way. Now, what's happening is that 297,000 and close to 298,000 new cases of invasive breast cancer going to be diagnosed in the United States alone, out of which 55,000 are new cases with DCIS. DCIS is ductal carcinoma in situ, which if you've kind of managed to hear me speak before, this is stage 0 cancer. And 43,700 women will die from breast cancer. Now, in Canada, things are a little different, probably to the factor of 1 to 10. And these are last year's numbers, 28,600 new cases, 5,500 deaths. Again, if we're looking globally, it's 2.3 million women diagnosed with breast cancer. And the survival rate is measured at 5 years, which is a whole different point of discussion we're not going to get into. So 7.8 million women are actually who are alive with breast cancer just in the past 5 years. Women are not just numbers. I mean, of course, who said it that one death is a tragedy, but millions is a statistic. But we're talking about mothers, daughters, grandmothers, sisters. All of them have families. All of these families are affected by either by dealing with this particular disease or, God forbid, by someone who is lost to this disease, because the survival rates are not improving. Now, breast cancer is almost a geographic disease. And what I mean by that is that if you look at this particular map, it's breast cancer cases out of population of 100,000. Blues are going to be less than 22 or 22. Then we have greens, 40, and then finally we get into yellow, orange, and pink. And those countries with pink have the highest incidence of breast cancer in terms of their population. So we're looking at primarily North America, some countries in Western Europe. We're looking at Australia, New Zealand, and Israel. Countries in blue are Sub-Saharan Africa, India, China, specifically coastal areas of China. So when it comes to genetics, everybody thinks, maybe not everybody, but a lot of people insist that it's a genetic disease. This actually disproves this whole idea. Breast cancer really is not a genetic disease, because we all know that, especially in North America and many other, and in Europe, there's a variety of different ethnic groups living here from different continents and different cultures. And we definitely don't see a difference between, let's say, ethnic Chinese women versus in North America. They have the same incidence of breast cancer as everybody else, compared to Chinese women that live in China have 1/7 of the breast cancer incidence. So there's something about breast cancer that maybe we'll explore a little further, and I'm not going to talk about breast cancer prevention per se, because we're going to just focus on thermography. Country number one is Belgium, and then followed very closely by Netherlands. So I'm not sure whether it's the Belgian beer and Dutch cheese, or maybe it's a combination of beer and cheese. It's not a laughing matter, of course, but that's very, very sad. We are also going to look at what is the age of breast cancer where it's most aggressive. And naturally, it's most aggressive of women under the age of 40. As a matter of fact, it's a #1 cause of mortality in younger women. And why I'm saying this is because, as we all know, younger women are not really screened or even looked at in terms of breast cancer. So why is the breast cancer, sorry, I have to admit people as we go along. Why is the breast cancer so common in developed countries? I think I'm going to tell you something that you already know. We're looking at many different varieties and different number of risk factors. We're looking at, it's not just limited to age. Naturally, of course, cancer rates will go up as we age, but we also are looking at hormone therapy. And when I talk about hormone therapy, we're talking about synthetic. We're all talking about older age at first birth. In other words, women are having children much later in life, and they're having few children, they're having few pregnancies, and therefore they start nursing much later in life. And that actually, each and every time that a woman nurses a child for 9 months or so, it reduces her rate of breast cancer by 3%. So someone who has 4, 5, 6 children, that definitely reduces their risk for breast cancer quite significantly. Alcohol consumption over the last 15, 20 years, alcohol consumption in women has exponentially increased. Diet, we can spend another webinar just on diet alone. Environmental pollutants, as we all know, things like certain chemicals that mimic estrogens, and finally iatrogenic causes. Iatrogenic simply means diseases caused by other medications. Now, naturally, if we affect our diet, if we affect our lifestyle, we become a little bit more heavier, and our gut microbiomes are going to change as well. Naturally, we're going to become more and more susceptible to any kind of cancer at a much younger rate. So the problem that at least I see, the problem is we have three problems. The current paradigm basically states that as long as we eliminate the tumor, and I like to use kind of this analogy of an iceberg, that the tumor is only visible from the outside. The 9/10 of the iceberg is actually submerged below the water surface. We don't see it, we don't address it. And unfortunately, I have to say that that's where we're missing most of the issues here. So as long as we can cut the surface, what we see on the surface, and or by different means, not necessarily surgically, we can poison this, we can radiate this. Unfortunately, the most important thing, which is beneath the surface, is not addressed. The other problem is that we don't pay any attention to prevention. What I mean by that is that we've done quite a good job in terms of preventing heart disease. We even are trying to prevent diabetes as it becomes more and more prevalent worldwide. But there's nothing, absolutely nothing about preventing breast cancer. And as I said, I strongly believe that in the majority of cases, breast cancer is a preventable disease. And finally, and this is probably kind of one of the most important things, is that we're confusing screening with risk assessment. I'll explain in a minute what I mean by that. Just because we are annually trying to screen women for breast cancer, it doesn't necessarily mean that we are assessing them in terms of risk. So here is risk assessment versus screening. If we assume that at some point in time, the etiology or the genesis of that tumor starts, let's say, with 2 or 4 or 16 cells, and it doubles every 90 days. So 2 becomes 4, and so on and so forth. After a couple of years, we're looking at a colony of let's say 5,000. Sorry, we're going back and forth here. 5,000 cells. After 4 years, you're looking at 65,000 cells. Finally, we're getting into millions of cells at 5-year mark, which is still undetectable by mammography. In the majority of cases, mammography will detect a tumor the size of a small pea, and that's going to be actually 4 billion cells. And in about year 8 or year 10. Now, this is an average growth. Some naturally will grow a little faster, some will grow a little slower. So in other words, someone comes in year 5 and gets her screening and says, no, you're negative, go home. Nothing is done after that. Okay, I'm clear, great, good news. And yet something may be developing. So what I'm suggesting is where thermography fits in is that you will see later on that basically raises a flag of some kind of an abnormality much, much earlier in many, many cases. Not always, there are always exceptions, but it will raise that red flag that we can follow up with these patients and kind of see who is at higher risk and who is at lower risk. Now, risk assessment again versus screening. With risk assessment, with thermography, we're looking at how your breast functions. In other words, what will happen versus structure. Structural tests are mammography, ultrasound, and MRI. The issue is that the structure is going to tell you if there is a change in structure, then something already happened. Before something happens, the functional side of it is going to be affected first. So that's what I mean by something that will happen versus something that already happened. And you saw that in the illustration before, as I showed that it takes about 8 to 10 years for mammography to actually see a lesion kind of with the size of a small pea, whereas in year 5, in year 6, in year 7, where it's still undetectable, but something may still be there. So, brief introduction to thermography. I'm sure many of you remember from last month, but I'll just reiterate a few things. What thermography is a diagnostic imaging technique that captures and visualizes the heat patterns emitted from the body. That's all it is. Now, we use infrared cameras to detect subtle temperatures. These temperatures are then color-coded and present as an image. This method basically is leveraged between the principle that bodily tissues provide various amounts of heat, because there's a difference in blood flow, there's a difference in metabolic activities. So that's kind of the basis of thermography. And what's kind of important about this is that it allows us to see as an application in certain circulatory issues, detecting inflammation, screening for potential tumors or other abnormalities. In other words, what is the definition? Thermography is non-invasive diagnostic imaging technique that visualizes infrared heat, which is naturally emitted from the surface of your body. Sorry, we're jumping here. How does it work? As I mentioned, infrared cameras used to capture the heat emanating from the breast surface. Then the heat pattern is then translated into a digital image called a thermogram, right? And then that particular thermogram displays with spectrum of colors. Each color represents a specific temperature range. Any of you who have had thermography would look at the image and you will see a color scale on the side of that image. So, can you see the difference? I hope that you can. Well, if you don't, I'll point out to this particular area versus this area. So on the side here, you see a color scale with different temperatures. These are degrees in Celsius. Darker colors are cooler temperatures, lighter colors are warmer. Where you see heat under the breast, it's perfectly normal. Heat in and around your axilla is normal too. But what's not normal is this particular area with all the structural kind of abnormality here as well. And why is this significant? Sorry, I just need to go back. Is because like everything else, and I'll go into detail here, everything is done as a contralateral comparison. So if we see something on one side, we want to see the same thing on the other side. We have two breasts, we have two hands, two sides of the face, we have two legs, two arms, and so on and so forth. And basically, we're looking for symmetry. Maybe in some artistic circles, symmetry is considered to be a boring thing. One can argue about that. But when it comes to thermal imaging and when it comes to your health, symmetry is basically the best thing that you have going for you. So anything that's asymmetrical and anything that exceeds kind of the normal limitations of thermal or temperature variation between 2 points of reference. Now, heat patterns and abnormalities, as I just mentioned, we're looking for asymmetrical patterns. We're also looking, sometimes it's not always heat, sometimes we're looking for cold spots. That may also suggest changes in blood flow, in metabolic activity, and all of this stuff often is associated with tumors or inflammation. And then what this is where the functional kind of imaging comes in, is because it detects changes on the cellular level. Those changes affect temperatures that come to the, or temperatures that basically emanate from the surface of your skin. Okay, next. So what's unique about thermography? Well, first of all, as I mentioned before, it's non-invasive. There is absolutely no radiation. There is no contact. It detects inflammation. And finally, it deals with physiological, in other words, what we call functional imaging. Now, against other modalities, we're looking basically thermography versus other imaging modalities. But I want to kind of mention something right up front. It's not a game that thermography is better or mammography is worse. They are all kind of complementary tests. So definitely they all have advantages and they all have limitations. So the advantage of thermography is that it's not invasive. As I mentioned, it's radiation-free, can detect physiological changes. Whereas, let's say, advantages of mammography is that it's highly effective in detecting tumors. However, there are also limitations to that. There's radiation, there is false positives and false negatives. So each and every kind of imaging modality has its kind of positive as well as negative sides to it. So what I want to kind of caution everyone here is not to, not to kind of overly promote thermography, because obviously it's not a panacea. It definitely, thermography is unique in its approach, but each modality has its strength. And when you combine them collectively, the clinical scenario of this type of information is going to be quite significant. So, in other words, in at least what we're proposing is to have thermography as an imaging modality because it's non-invasive. If somebody is high risk, maybe we should image them more aggressively. We could start with an ultrasound. When necessary, we can escalate to a mammogram. And finally, we can also use the MRI as well. For women who are low risk, and again, keep one thing in mind, that low risk does not necessarily mean no risk. Risk is always present, but again, statistically, it's very, very low. Probably we don't need to be as aggressive as with women who come out with high risk thermograms. Now I want to switch to something that we can see sometimes, sort of visualize, but the process is basically the process in terms of cancer pathology when it comes to breast cancer. So the process is called angiogenesis. Angio stands for blood, and genesis, as we all know, is the beginning. So how does it all start? So imagine that there is a small colony of malignant cells. They finally connect to a major blood supply. And the reason they do that is because malignant cells definitely require more nutrients. They're metabolically much more active and they grow at a very fast pace. And the problem with malignant cells is that they don't die, right? So that mechanism, for some reason, it doesn't exist there. So, and because they don't die, they just continue to grow and grow and grow. And metabolically, as I said, they're more active. So once they are connected to that additional blood supply, they secrete chemicals to keep that blood vessel in a state of vasodilation. In other words, to keep it open all the time. And therefore, it will produce a little bit more heat than the surrounding tissue. So detecting signs of angiogenesis can definitely warn us about early detection when it comes to breast cancer. Now, angiogenesis is actually, it's a normal process. It's not something unusual. When it comes to normal process, normal, regular, healthy pregnancy with placenta, that's kind of another example of angiogenesis. But again, there is the beginning, the middle, and the end to this after 9 months, where when it comes to cancer tumors, there is no end to this kind of in a natural way. So what I want to show you is this. So there are microscopic tumors that are present in us all the time. And as I mentioned before, once they kind of connect to that blood supply, at that point in time, something changes and something starts to develop a great deal. So, sorry, let me just check something. The autopsy of 80% of 80-year-olds shows us that they have DCIS. Remember, ductal carcinoma in situ, which is really a non-threatening kind of condition, although it is classified as cancer, but it's stage 0 cancer. Now, 80% of 80-year-olds, they have passed away not from breast cancer, they have passed away from some other kind of condition. And yet, when we look at that group, we see that 80% of them have DCIS. In other words, that's not something that caused their mortality. We can look at different things, but for the purpose of our discussion, we'll just end here. So from harmless to deadly, again, look at the tumor. Tumor connects to major blood supply, starts growing. And then once we give them certain drugs that are called angiogenic inhibitors, that tumor is going to shrink. So there were a lot of studies that were done where they were put on angiogenic inhibitors. The tumor shrinks, they take them off, the tumor starts growing again, they put them on, the tumor shrinks again, and so on and so forth. So we know that without blood supply, things are not going to grow very quickly or at all. And therefore, if the angiogenesis is the tipping point between the harmless and harmful cancer kind of development, doesn't it make sense to know about it at the earliest possible time? And this is where thermography comes in. I'm not going to suggest that thermography can say, oh, this is an angiogenic process. It will definitely look at someone who is high risk, and then we can escalate to kind of other types of imaging modalities as well. So I want to introduce something. The ones that have had our reports are familiar with this. The ones who haven't, I'll just take a minute to explain what this is all about. TH1 is the lowest rating. TH stands for thermography, and it will have a particular score. We have both quantitative as well as qualitative analysis in our kind of analysis of imaging. In this particular case, you will see that everything is fairly symmetrical. TH2 will see some asymmetries unilaterally. TH3 is going to be more asymmetries and maybe exceeding certain temperature limitations. TH4 is going to be more dramatic, and TH5 is going to be very dramatic. Now, this is all based on statistical probability of risk. And that's basically how we can triage women in this particular way. So someone gets a baseline. That baseline is either TH1 or TH4 or whatever, and then we can follow them up a year later or 6 months later, whatever is necessary, to see if they're stable, if they're getting better, if they're getting worse. I'd like to show you a case, a real case that I've had. This particular woman came to us, as you can see, quite a few years back. And this was definitely an interesting case that I wanted to share with you today. She came to us in March of 2010. You will see that the right breast, this is her anatomical right breast, was scored with a score of 75, which is low end of TH3. Both breasts are fairly vascular. However, there are some differences in temperature and certain patterns that positioned her into a TH3 category, although low end of TH3. Her subsequent appointment, so this was March 2010. Her subsequent appointment was in January of 2011. So it was like 9 months or 10 months, something like that. And here her right breast score has come up from 75 to 85. Again, it's difficult for me to show this, but there are certain very, very subtle changes in temperature between the two images. And that's why the score is going up. Now, from January of 2011, now she comes in November of 2012. The right breast now has a score of TH5 with a very high, rating of TH5 with a very high score of 150. Why this is so? Because as you can see, more and more this becomes a very, very kind of unilateral presentation. This nipple versus this nipple temperature, I think, was over 5 degrees Celsius. Now, if you think about it, it's quite significant. Where normal limit is up to 1 degree, this is something like 5.5 degree difference between two nipples, same person. So she escalated right away. Unfortunately, she was diagnosed with invasive ductal carcinoma. She comes back in March of 2013. She had lumpectomy and she had chemotherapy. And now she comes down from TH5 to TH2, subsequent to her treatment. In her particular case, it really worked very, very well. I remember, she came with her daughter. They both started crying because you never know. And this is such a significant change in a very kind of positive way. They both started crying with kind of joy, which was very nice to be a witness to. Now, remember the dates, March 2013. The next follow-up is July 2013. So just a few months. And I'm going to flip back and go back to her next follow-up. Maybe it's a little too fast, but I'm going to suggest that she lost a lot of weight. Her score came down from 50 to 40. And I asked her, what exactly are you doing? She says, well, I changed my diet. I'm exercising. She was doing all sorts of kind of therapies, including things for her psycho-emotional well-being. I couldn't believe it. She looked like an athlete. And by the way, she looked at least 10 years younger as well. So great, we're moving in the right direction. Now, again, July 2013, the next one, the next one is October 2014. And as you can see, again, she gained a little bit of weight, and now from 40, the score goes up to 65 with the right breast, still within low kind of risk. But I started asking her, what exactly did you change? I mean, it's quite a significant change again. She says, well, the diet was a little too restrictive for me, and I'm not as diligent with my exercise routine. So I showed it to her and I said, listen, I don't think that you're moving in the right direction now. I mean, the score is not significantly higher, but I think you should go back to your restrictive diet and heavy duty exercise, because it definitely worked for you. I'm not sure whether she listened or not. As you can see, this was almost 10 years ago. But the next thing, she comes back the following in March of 2015, and now her left breast, which is this one, is starting to give us some kind of odd signals. There are certain patterns that weren't there before. Both kind of upper portions of her breasts are definitely looking at most likely some kind of estrogen influence. We're also looking at quite significant kind of change in the left breast as well. So she goes again from TH2 to TH3, and I don't think I have any follow-up with her. Don't think so. No. But she moved from the area where we're at right now in Toronto. She moved to British Columbia. I don't think I have any further follow-up with her, but we kind of kept in touch, and then we lost that communication. She was diagnosed with recurrence of breast cancer in the opposite breast on the left side. So you can see that over these last 5 years, we're looking at quite a huge progression from when she just started to 5 years later, going through her breast cancer and then subsequently dealing with recurrence as well. I wanted to present this particular case because it's over many years, and naturally we have a few other cases like this. One thing that drives me up the wall is that when we say someone is high risk, and then they go and get imaged with a mammogram that comes back negative, which is great. They don't do anything else. They're just waiting. And if somebody is high risk, I would suggest to all of the practitioners that are listening to us right now, don't take this for granted. It's not a fluke. They are high risk because something else is pushing them into that high risk category. Sit down with them, figure out how you can minimize that risk. In other words, is it her diet? Is it her hormone balance? Is it her psycho-emotional health? Is it her thyroid? There's so many different components to this, and see how you can mitigate that risk. Because just because someone comes back negative on the mammogram, again, as I mentioned to you before, she could be in year 5, year 6, year 7. It's still not detectable by other technologies, and yet the process is there. So you can see how visually, not only as a practitioner you can see something, but how visually you can present that to a patient and say, well, you're moving in the right direction, or you're not moving in the right direction. And they understand this very well. So it's very helpful. So how can we use this in your clinical practice? We can use it definitely as a diagnostic aid. In many cases, women will come back with equivocal mammography or anything else, where maybe they don't want to have a mammogram for different reasons. If there is a high-risk thermal imaging, in many cases, we'll ask them to escalate, and in most cases, they will listen. As I said, thermography could be used as an early warning system. Indispensable how we can kind of triage women into low risk, medium risk, and high risk. And we can start doing something about this. So risk assessment is very, very important. And finally, we can look at treatment monitoring. As you have seen just in the case that I presented, her lumpectomy and chemotherapy at that point in time worked wonders for her. So that was something that she was very, very happy to see. Sometimes it works, sometimes it doesn't work. And finally, as a prognostic indicator, it's very, very important to see which way they're heading as well. Now, in terms of treatment monitoring, just want to show you the difference that 6 months makes. And what I mean by 6 months, this particular patient wasn't even a patient of mine. It was from another physician. She was taking indole-3-carbinol, which is an off-the-shelf substance made from derivatives of cruciferous vegetables. And the image on your left, which is a lot of activity, a lot of redness, a lot of heat, maybe even something more kind of developing in the left breast. And by the way, I've always kind of felt that, at least in my analysis, it's about 7-3, maybe even 6-4 of left breast higher risk versus right breast. And just recently, I came to understand why. In the majority of cases, left breast in women is going to be slightly bigger, slightly larger, as you can see in this particular case as well. And obviously, the more surface you have, the more likely something is going to develop there. Now, 6 months later, we can see that everything has come down. All this heat, all this inflammation, all this thermovascular activity based on vasodilation that's usually caused by excess estrogen or estrogen metabolism, that was taken care of by indole-3-carbinol over 6 months. Now, again, it's not a panacea. It's not going to work for everyone. In this particular case, it worked very well. So I'm just showing that as an illustration in terms of treatment monitoring. It could be something else. It could be acupuncture. It could be, there are so many different therapies that are so useful. But as I said, this is just an illustration. Now, I want to bring up something that comes up in my conversations, and a lot of people are asking, is the cold water challenge necessary? Versus I went to someone else and they said that their camera is so sophisticated that they don't need to do anything. So what I call cold water challenge is dynamic versus static thermography. Let me explain what it is. Dynamic thermography involves monitoring the skin's temperature response to an external stimuli. In our particular case, it's cold water, okay? Whereas static thermography is something that we do anyway. We start with that baseline, okay? Then we perform the cold water challenge, and then we do the dynamic, or what we call functional imaging, if you've seen any of our reports. What is the advantage here? The advantage is that if I see something suspicious on the baseline image, I want to kind of isolate that area, and I want to stimulate or kind of challenge that area with a simple test. What does it do? So I'm going to compare that area on the functional image, whether that area is going to be cooling down like the surrounding tissue, and whether that particular point of interest is going to cool down as the opposite breast as well. Sometimes it does, which is a normal response, and sometimes it doesn't. And when it doesn't, I'm asking a question, why is that so? So the body will react to a temperature change. And as a clinician, you can understand that it could be a vascular, it could be neurological, it could be a muscular system involved, right? So it will give us an early kind of warning system. It also allows us to see how, in terms of treatment monitoring responses, let's say we're not only just talking about the breast, let's say we're talking about muscular skeletal issues, it also enhances the specificity. In other words, if that area is not cooling down as the surrounding tissue, why is that? So it helps us avoid the false positive. And what I mean by that is that let's say we have kind of a potential kind of questionable area with a static test or a baseline study, and then we perform a couple of minutes later, after the cold challenge, we perform the functional study test. Well, if that area goes back to normal, well, that's great. That's a normal physiological response. This is a normal, healthy breast. But if it doesn't, it raises the question, why not? Okay. Obviously, not everyone responds this way. And we don't know whether how a woman will respond to this, but it makes me definitely way more suspicious. So it enhances the specificity of our reports as well. So the static thermography, as I said, is basically taking an image and looking at it. But when you're just doing that, all I can say is just you're doing half of the examination, because it's so easy to perform the other half to give us that additional information. Something that's, I want to stress, probably one of the most important things, and probably one of the basic issues that are missed with many other technicians that are performing thermography, I would say totally incorrectly. This is an image of our report. That's at least one page of our report. As you can see, that in this particular case, we're looking at the baseline study. And then after the functional test was performed, now it's the functional study. So if this particular area that I'm concerned about here and here is, if it's not cooling down, I'm definitely escalating and telling the patient that something may not be right. I'm not sure exactly what it is, but I will definitely escalate. Now, when it comes to breast health, as I said, I strongly believe that the way to improve the outcome and the way to improve statistics that we've started with at the beginning of this presentation, I just don't accept so many people getting breast cancer, and I certainly don't accept so many women losing this battle to breast cancer as well. So in my opinion, if we can stratify them in terms of risk, that would be at least somewhere we can start. Someone who is low risk does not necessarily need annual mammography, in my opinion, just like someone who is high risk definitely needs to be looked at more vigilantly. Benefits of incorporating thermography into your diagnostic toolkit. Remember, it's non-invasive, it's pain-free, and this is probably not the only thing, but one of the significant factors that have attracted me to thermal imaging 25 years ago. It provides you with early detection. It's a comprehensive view. It complements, it does not negate other modalities, just like other modalities do not negate thermography. It definitely complements. And finally, the patient has comfort and safety. It's additional information. We don't have to radiate them. We don't have to infuse them with radioactive gadolinium. We don't have to harm the patient to get the information. Last but not least, I want to kind of mention that as Canadian Association of Clinical Thermography, we want to establish thermography as a key imaging tool in healthcare. And definitely that's going to kind of help us educate practitioners and as well as patients. Thermal imaging definitely is a transformative application in healthcare, and we want to share that as much as possible with you. If you have any questions, if you have any queries, please contact us. Here's your contact information. It's connect@thermographycanada.com. You can call us at this particular phone number. Also, you can go to the website called thermographycanada.com. And finally, with a few minutes left, maybe we can get into Q&A session. Catherine, are you still there?
I certainly am.
We have any questions?
All right, so we're going to get started here. So again, everybody, please, thank you so much again for joining us today. Please take the time to put your questions into the chat box and we're going to get started. So no question just yet, Dr. Mostovoy, but a thank you for your excellent presentation. So thank you so much, Harriet, for your message. We appreciate
You're welcome.
that. So while we're waiting for some additional questions to come in, another lady just said, thank you. Sorry, need to check out, need to leave. I just want to remind everybody as well, too, that the Canadian Association is certainly very open to receiving your feedback on additional topics that may be of interest to you as a practitioner as well. That is definitely something that Dr. Mostovoy is very interested in hearing as well. So please feel free to either reach out or even put it here in the chat message. I'll capture that, make sure that we get the feedback back to everybody.
I have a question.
All right,
Before we get to I have a question too.
Oh, you have a question.
What's the next? Yeah, what's the next subject next month?
So the next one is on dental and thyroid. So this one is coming up next month, and we're going to go ahead and get this out. So I just want to preface this. So everyone, this month was a little bit crazy, and I will follow the sort for this one. We didn't get it out as early as anticipated, but next week we'll be sending out the one for November, and the one for November is on dental, cranial, thyroid health, and that's also very important, very much linked also to breast health. So that's our next one coming up. All right, so here's some questions. We've got the first one. Do you know why it is that thermography used to be covered by OHIP in the 70s, I believe, and now it is not?
A very good question. Thank you, Pam. Thermography was covered to the tune of $19 and I think 50 cents in 1970s. Nobody was practicing, and when there was a resurgence of thermography in early 2000s, $19.50 is just not going to help anyone with thermal imaging, with the cost of the equipment, with the cost of providing the service, with the cost of interpretation, and so on and so forth. So if at some point in time Ontario Health kind of Ministry decides to update or upgrade that amount, I think it's going to be very helpful. Some insurance companies do cover thermography as medical imaging not covered by OHIP. So if anyone has that insurance, that could be useful for some people.
All right, thank you. All right, now the next question is, do breast implants make a difference
in diagnosis? Breast implants should be temperature neutral. In other words, they're not cold, they're not hot. We do have a lot of women actually with breast implants. So to me, it doesn't really matter whether it's an implant or not because they're temperature neutral. We had last year, we had a speaker that was presenting, if you remember, what was her name? She was talking about specifically about breast implants and certain risks associated with that. So maybe you can get back to us. I think we have a copy of that presentation, and maybe we can share that with Susan.
Yes.
Again, not to alarm you or to scare you, but since you asked the question.
Absolutely. So Susan, we're happy to follow up with you on that information as well. All right, any other questions before we wrap up? All right, no other questions coming in. So again, we want to thank you on behalf of the Canadian Association of Thermography. I want to thank you, Dr. Monsterboy, for leading the charge on this, and for all of those who attended today and or listening to the recording afterwards. Please keep your feedback coming on topics that you would also like to see. We've got a year planned out of monthly meetings, but again, we're also very interested in hearing from you to make these more impactful as well. So thank you all. Please stay tuned to your emails. We will be sending out next week before the end of day on Friday the next registration for signing up for November, which is again your dental cranial thyroid, and how that connects to everything as well too. So thank you again. Dr. Musboy, do you want to say anything before we break out?
Yes, I understand that we reached a limit, capacity limit, and some people, so maybe we'll, for next time, we'll
Yes.
expand our capacity so that nobody is left behind. I feel like a political leader now. I'm grateful for everyone who's interested, and as I said, let us know what interests you have. We'll definitely try to accommodate. Breast thermography is very, very kind of near and dear to me personally. But I think next month we're going to have something spectacular when we're talking about thyroid, which is so prevalent, and dental pathology as well. So if you think this is of interest to you, please register early. Thank you, Catherine.
Thanks,
All the
everybody.
best to everyone. Stay healthy. Take care.